Hello, everyone. I'm Dr. Carmen Puliafito. I'm here today with Dr. Yasha Modi, who is currently Associate Professor of Ophthalmology at the New York University School of Medicine, but will be moving to be Vice Chair at the estimable and famous Manhattan Eye and Ear Infirmary, part of Northwell Health. Congratulations, Yasha.
Well, thank you. I really appreciate it. And it's always a pleasure talking with you.
So today we're going to talk about TKIs, and in particular, one, the EY 1901 drug from EyePoint Pharmaceuticals that was used in a clinical trial for diabetic retinopathy, the VERONA trial. And you presented
Yep.
this at the ASRS, and we'd like to know more about this. Um, Tell us about
Yep.
the TKI involved and what its characteristics is.
Yeah. I think first it's important to realize there are a couple of different molecules that are there. There's vorolanib, there's axitinib, and there's sunitinib. And vorolanib is the one that's specifically linked to the intravitreal insert that makes up EYP 1901. Now, the difference is that typically when we think about using Eylea or a flipper or for instance, faricimab, those bind VEGF at a extracellular level. And these tyrosine kinase inhibitors, they're small molecules and they block intracellular VEGF receptors. They also have zero order kinetics, so that allows the opportunity to have kind of a long, slow release of medication. And the ultimate goal is for patients to go about 6 months between injections. And so that's really what these studies are looking at. That could be either when you look at the Ocular Therapeutics program or whether you look at the EyePoint program, the metric for redosing is going to be about 6 months. And a lot of that has been shaped by, for instance, in the EyePoint program, the DAVIO 2 results, which really show in AMD excellent efficacy, really going out to about 6 months. And when you look at the Lugano and the Lucia studies, that is a study that will be dosed every 6 months, and we'll sort of see what kind of durability we're getting through that window. Now, in the study that I presented at the American Society of Retina Specialists, that's the VERONA study, which is the phase 2 program for diabetic macular edema. And this really looked at two different doses of EYP 1901 given at the time of an aflibercept injection versus just the control of aflibercept. And it was essentially, and it was a decay analysis to getting primary endpoint. And what we see is that effectively about nearly 2/3 of patients in the higher dose arm were able to get out to about 6 months without getting retreatment. So that's excellent efficacy data. Now, what was sort of surprising was that when you gave the medication in conjunction with aflibercept, the visual acuity improvements were much faster than just aflibercept alone, and the anatomic benefit was seen much faster relative to aflibercept alone. So kind of an interesting drug, works at a slightly different mechanism of action, and I think could be really synergistic to the current medications that we have.
How would you presume using it? Prime the patient with aflibercept and then give them the tyrosinase kinase inhibitor shortly thereafter?
I think that's a really great question. When you look at the DAVIO 2 study, they were all previously treated. When you look at the Verona study, they were all previously treated. And so all of our data suggests that these are going to be used kind of in conjunction, probably with anti-VEGF medications. Now, what's interesting is the Lugano and the Lucia study are going to have treatment naive patients in the study. So we'll understand, is this something where it can be used as a sort of monotherapy? But more likely than not, I think what we're going to see is that this is going to be used in conjunction with anti-VEGF medications with the goal of ultimately lowering the total treatment burden. Now, I think the other thing that's going to be really fascinating, and this is kind of the joy of retina, is a clinical program provides us some value of a medication. But clinicians have to figure out how are we ultimately going to use this. If you look at like kind of the box plots in DAVIO 2, you may see one patient that gets the injection and then requires zero injections, like zero anti-VEGF injections to follow. And then another patient may require one at some random time point, and another patient may require three or four, indicating the efficacy of the medication is really not there. So I think this is going to be one of those things where we're going to figure out who is responsive to this medication, which we would expect about two-thirds of patients to really be very responsive, and then try to figure out a strategy to not only lower their injection burden, but also lower their visit burden.
What's the phase 3 trial like? How's it designed?
So the diabetic macular edema one is not publicly available yet in terms of its design. As
Hmm.
for the Lugano and the Lucia one, which is and is fully enrolled, that's essentially a injection and then a retreatment at 6 months. So in that study, which is different from the Davio 2, is they're not waiting to allow some level of critical like decrease in their vision or their anatomy before they retreat them. But of course, all the usual safety mechanisms are still built in. So that is, if a patient cannot get out to every 6 months in the experimental arms of that study, then they are going to be retreated. And this is being made in comparison to sort of the standard of care every 8-week aflibercept.
In the Verona trial, once again, what percent of patients didn't need treatment at 6 months?
What percentage of patients did not require? It was just under two-thirds of patients did
Yeah.
not require a supplemental injection. So
Mhm.
that's pretty amazing if you think about that two-thirds of your patients who were heavily treated beforehand, getting injections every 4, 8, 10 weeks, are now able to go 6 months without a treatment. Now, I think one of the other things that we probably have to discuss, because it really doesn't get enough sort of credit, is the port delivery system. So when you look at the port delivery system, now granted that is a surgical procedure, when you administer that medication, whether it was in the DME study or in the AMD study, about 95% of patients went injection free, supplemental injection free in that 6 month window of time. So really the gold standard of long-term therapy is arguably the port delivery system, but that's hampered by the fact that it requires a surgery. There are complications from that surgery. And so in the right patient, when it's administered by an excellent surgeon, it's a really great option. Here we're talking about tyrosine kinase inhibitors that are administered in the office, very similar to that of an intravitreal injection. The efficacy is not as good, but on the other hand, still two-thirds of patients are able to get out without injections.
Well, it looks like the traditional anti-VEGF agents will still be there, and the newer ones are much more durable in their efficacy, but they're going to be complemented by TKIs.
I completely agree with that strategy. I think that's basically going to be the way that we think about this problem in the future is that you have these really fast-acting anti-VEGF medications and this more zero-order, durable tyrosine kinase inhibitor on board to kind of prevent those relapses where patients may be losing vision.
And the reason TKIs weren't injected intravitreal is they work intracellularly, and they're not extracellular blockers.
That's right. They're intracellular blockers, so slightly different mechanism of action. So I'd caution people to sort of lump them into the fact that, oh, it's just another anti-VEGF. Yes, that's what it's doing. It's blocking VEGF receptors, but the mechanism of how it's doing so is different. And that in itself can provide unique sort of therapeutic effects.
Well, this is exciting. And thank you for sharing your insights about the early clinical trials. Very promising.
Yeah, I certainly agree.
Thank you.
My pleasure. And thanks so much for having me be here.